Okay. Okay, Dr. Lee, you can start your section.
Yeah. Thank you, Professor. Okay.
Dr. Lee, you want to start the section?
Yeah.
Okay.
Chen Guangli.
Okay. So
Okay.
hi
Okay.
everyone. Hi everyone.
I have
And
and
the Professor
Can you
Lee
see
and
my screen?
everyone. Yeah. Yeah, we can see your slide. Please just talk about your the emergency intervention in acute massive pulmonary embolism.
Dr. Lee, you have to start a section. You have to start the first time preface. Let's go from
Okay. So hi everyone, I'm Dr. Li Zhenguang Li from National Taiwan University Hospital. I'm happy to have this discussion to have this APSC Cloud Forum of Cardiovascular Disease series. So this session I aim to have the young leader arena for the intervention solution and the video demonstration in critical peripheral vascular disease. We have several topics today to have the discussion, and also we have many experts. So
several topics today.
हाँ तो यहाँ बैठ के क्या करेंगे? मैं तो रूम पे जा रही हूँ। चलो छोड़ो, मैं रूम पे जा रही हूँ। मैं तो यहीं बैठ सो जाऊंगी। कंसंट्रेशन नहीं बनेगा मेरा।
Okay.
Go on the next slide. It's okay.
Okay.
Then go on next slide. Preface. Next slide.
Okay. Next slide. Next.
It's on.
Yeah.
Okay. So this is due to the technology, we have several topics going to talk about today. And slide next. So we have several speakers. So allow me to introduce myself and our co-chairperson. So this is the Sanjoy Tani from India. He's a professor, very famous professor, focused on the peripheral intervention. So he will be here to co-chair this session. Next. So next. So next. So allow me to introduce the first speaker. This is Dr. Ding Huyan Lin from Mountain. He is a cardiologist and is focusing on the peripheral intervention. Today, his topic will be the how to treat the emergency intervention in acute massive pulmonary embolism. So please, Dr. Ding Hu Lin.
Thank you for your kind introduction. I'm Dr. Ling from Vietnam National Heart Institute, like my hospital. It is my great honor to be here to share my case about the intervention. I'm really sorry that I have an urgent meeting. Also, I'm a little bit rushed now. I hope you can understand. Okay, so it's my case, it's my disclosure. This case was admitted to my hospital about nearly 1 year ago. She was a 27-year-old lady. She had pregnancy at that time, her first pregnancy in 16 weeks. And she was admitted due to sudden onset of dyspnea. At the cardiac ICU, she has NIHA class 4, heart rate is pretty fast. BP is 90/60 on dobutamine, and we check the fetal movement. The fetal is still moving, has some kick. So on the lab test, you can notice the elevation of the troponin as well as the cardiac biomarkers like BNP. And she had the anti-lupus agent, which is positive, and it might be the cause of the thrombosis at that time, and the D-dimer was elevated as well. So She was in a very urgent and bedside echo show right ventricular failure. So she was sent to multi-slide CT, which show you see the bilateral huge thrombus of the PA. You can see it here. Yeah, and we did not see the perfusion of the distant pulmonary arteries. So we know that what did the guideline recommend about this case? This case is hemodynamic unstable and pretty high risk. So it is the indication for systemic thrombolysis. But if there's any contraindication or failure of thrombolysis, catheter-directed treatment might be indicated. And you know that this woman, she had pregnancy, and it looks like she had a relative contraindication for thrombolytic therapy. Of course, after a very long discussion with the heart team and family members, we decided to do catheter-based intervention. Of course, we know that in 16 weeks of the pregnancy, there might be some X-ray problem for the fetal, but we did think that saving mother's life is much more important. Yeah, we know that currently there were some devices for transcatheter pulmonary embolism intervention, like the echoes using the ultrasound. We have some infused devices on a very nice and fancy device like flow retriever, and we have the catheter aspiration system like the Inigo from Penumbra. A very nice system, the angiovac that can aspirate a huge clot. Yeah, there are many things that we can use for pulmonary embolism intervention. And of course, it did have some clinical trial to evaluate the efficacy as well the safety of the devices, but it's that only case series and there are not any randomized trial, only retrospective or single arm trial or case series. So the evidence supporting the use of these devices are not really adequate. And of course, we do have some ongoing randomized trials. You can see the Peripheral to evaluate the ecosystem, the P-track peerless to test the flow retriever and some other devices. But at that time, we are waiting for the result of these clinical trials. So the only system available in our place was the Penumbra system. It included a large bore CT aspiration catheter, might be 6 French or 8 French. It included the engine. It was a vacuum pumped to deliver suction to aspirate the thrombus. An optional equipment was the separator that can be used to help fragment and mobilize the clot so that we can be able to aspirate the clot easier. Yeah, so we perform the right heart catheterization using the femoral vein, and the PAP is 60 plus millimeter mercury. And on the PA angiogram, you can see that the total occlusion of the left PA. It is the selective left PA angiogram. So we use the 8 French aspiration catheter and try to engage to the left PA. Try to aspirate as much as possible. We did have the right to fragment the clot. Yeah, and after multiple and on the right side, the angiogram show the um, oh, yeah. Now you can see my slide again, and you can see that we can be able to restore the flow. Yeah, and on clinical course, patient was stable, heart rate decreased, the BP was stable, 120/85. Oxygen saturation was 96% on. So PSP decreased as well, but quite good, and she was discharged 3 days later. On after the procedure, we switched to enoxaparin, then vitamin K antagonist. Several months later, she had a successful delivery, which is quite nice. So in conclusion, it is just not a very fancy case. There's no new technique. There's no fancy toy or devices, but we present this case to show that the catheter-based intervention can be an effective approach in case of PE, and we just need the basic equipment to do this. But we should bear in mind that treatment success can be varied. It's not like PCI that we should not aim for perfect flow. Good enough restoration of flow can be good enough. Yeah, because sometimes some clot can be aspirated, some clot we could not be able to aspirate, but it is fine as long as you can restore the flow as much as you can. Yeah, and that is that on the new novel devices like the echoes of flow retriever are not available in most of the countries. So I think that up for now, the interventionist should be familiar with all the technique that can be used to aspirate the clot in the scenario of pulmonary embolism. Thank you very much for your attention.
Thank you, Dr. Lin, for showing this interesting case. Main embolism was in left pulmonary artery?
It was both in both sides, but when we perform the right side, you can see the clot was here, but it was restored partly so that we could see the distal pulmonary flow. Yeah,
Can you
on
show
the
the flow in the left pulmonary artery after
after
thrombus,
okay,
after thrombus removal? Can you show
yeah,
the flow in the left pulmonary artery?
yeah.
Yes, it's much better.
Yeah, much better.
Very good result. Congratulations for saving a life.
Yeah.
Very good.
Can I ask one question?
Yes, please. Go ahead.
Yeah. Sometimes the mechanical thrombectomy is very difficult to have the endpoint for the ending of the procedure. As you can appreciate that there's still a lot of thrombus over there. So what is the proper endpoint that, yes, stop here. We have done a lot, that we have done a lot to do a lot of thrombus. So what is your endpoint, or what is the current strategy or consensus about when to stop?
Yeah. Excuse me, can you repeat the questions again? My connection was not so good, so I missed it. Yeah.
I mean, the mechanical thrombectomy, what is the endpoint to stop the procedure? Because as you can see, there is still a lot of thrombus after the thrombectomy. Of course, we can still do the thrombectomy as much as possible, but is there an endpoint that is, yes, we can do it, stop here to end the whole procedure? Do you have idea about that?
Critical questions, and we did have the same problem when we do the suction for like renal artery. So normally, you know, that for me, the restoration of the flow is a good endpoint. And if I did not restore the flow, I wouldn't be happy to stop. But if I can restore the flow, it is good enough. And you know, my case, it lasted like 2 hours, and we sucked out a lot of blood, and we didn't need to have blood transfusion to this lady. So I do not think that a very long procedure like 3 or 4 hours, try to suck as much as you can is a good approach. And you are very right that we should know when to stop. So yeah, and even in this case, you see that the right side is not very good flow compared to the left side, but it's all we can do. So yeah, happy like that. And of course, I think there's no absolute answer for that. Of course, you can see the RV improvement, the PASP improvement, but the improvement did not come immediately in the cath lab. So, I mean, if you ask me about the endpoint, I think the flow is the most important endpoint for me.
So here we have one question online that so in limited resources, can we use the pigtail catheter to do the direct thrombolysis? Can you share your experience?
Yeah, it is very practical questions. For me, I did several cases without the penumbra system. So I use manual aspiration using the system that we use in PCI. I mean the same mechanism as we use in PCI. We use the 50 millimeter syringe. We make the you know that the negative pressure, but we don't use the pigtail catheter because the pigtail catheter, you know, that is not large enough and has many holes. So I use a guiding catheter. I use a 6 French R4 guiding catheter. We try to go as far as we can, and we connect to the aspiration system, and we try to suck it manually many times, and I think it's quite okay.
Okay.
Yeah,
So
it's okay. Yeah.
yeah, I think it's okay. So I think we have a very good discussion, and okay, so we are going to move to our next speaker. Okay.
Thank you so much. Thank you.
Okay, thank you so much. So the next speaker will be the Dr. Rendra Mahadhika from Indonesia. So he will going to have a talk about the interventional solution for the severe venous thrombosis of the lower limb. So, Dr. Rendra.
Thank you, Dr. Lee. Now I would like to share my slide. It's open.
Sir, I have one question.
Is it my slide clear, Dr. Lee?
Yes,
Okay.
very
Thank
clear.
Okay. Thank you very much, Dr. Lee and Dr. Sinjo, for the kind introduction. Good morning, all distinguished panelists and speaker. My name is Rendra. I'm interventional cardiologist from Surabaya. Surabaya is the second largest city in Indonesia after Jakarta. So I invite all of you come to Surabaya, beautiful city in my hometown. I would also like to express my gratitude, Prof. Lee, to inviting me as a part of this faculty session. Today, really, I fully honor Prof to represent Indonesia to discuss the theory, the interesting topic about the interventional tool in the severe DVT. Okay, in the next 20 minutes, I will discuss about the topic of DVT and intervention. Let me begin with the epidemiology of DVT. In Europe and United States, okay. In Europe and United States, the incidence is reported around 1 until 2 cases per 1,000 per year. Interestingly, in our data in Asia, based on Korean data, is lower, 0.2. But however, despite this lower incidence, we have a severe problem. We have mortality risk until 20% with the first year after diagnosis of VTE. And the interesting case is what is also important is all of the DVT, almost the provoked DVT. Provoked DVT is clear risk factor related to prolonged hospitalization. Is there any cancer or surgery? These all of our factor in many cases will be preventable if we have good strategies. So I will edit some data, some good data. I don't know this is good or bad. Yeah, traditionally we emphasize the lower VTE incidence in Asia. Based on the Gulf VTE, Asian people, despite we have lower incidence, but there is higher mortality rate. It's around 15 point per 100% years. It's higher than the global population. So this is a big problem for us. So discussing DVT is good solution for us to solve this problem. And what happened in Asia? The data show us that in Asia, DVT especially, we have more female and non-smoker and a lower BMI, and the proportion of Asian people had a more active cancer. And the big problem also that we have data that the Asian people receive more not good therapy. There is still no anticoagulant higher if we compare with another country. So also we have the problem. Compared to stroke or myocardial infarction, VTE or DVT doesn't always receive the same level of attention. Either from physician or the general public, this situation can be illustrated by this iceberg phenomenon. What we see, and the diagnosis is only smart in upper of the surface, but in the under the surface still remains great case that under recognized. So if we see deeper, what happened there? DVT actually drive this hidden case of it can be explained through what we call the virtuous triad. Virtuous triad consists of the 3 major risk factors: endothelial damage, stasis, and hypercoagulable state. For example, endothelial damage can occur after surgery or trauma leading to thrombosis. And venous stasis is seen in the conditions such as the pregnancy, heart failure, and then prolonged immobility during the long travel. And same as in hypercoagulable states is calmed or triggered by the cancer, nephrotic syndrome, or hypoestrogenic state. This mechanism explains why VTE or DVT is like an iceberg phenomenon. We only recognize the visible part, only the major risk factor we can see. But under the surface, there are still many more patients with unrecognized risk factor who may eventually can be serious, even like DVT or like the previous speaker can be the pulmonary embolism. So we can do the good strategies for DVT or pulmonary embolism. So we back a little back to remind us for what is DVT. DVT, if we find a patient with thrombosis in our vein, and we can classify into the proximal into the distal. We say proximal when we see the thrombus in the popliteal until the ilio vein or iliofemoral vein. But we found the thrombus in under popliteal vein, we call it calf DVT or distal DVT. And then DVT can also be divided into the two kind of DVT. Provoked or unprovoked. We see provoked if there is clear risk factor like cancer, like after surgery, this is provoked. But unprovoked still not clear what is the risk factor of DVT. And the provoked DVT can be also be divided into the transient and persistent. Persistent like the cancer. Okay, and after we know the definition of DVT, we know the classification of anatomical DVT, we also have the severe type of DVT. We call this type with plekmasia cerulea dolens. Here we see in the picture A, we see the blue leg. This is the severe limb-threatening venous outflow obstruction, often called with massive DVT. And this can progress to venous gangrene. And if there is still good collateral, we see the skin still white. So we call it plekmasia alba dolens. So there is not more severe than dolens, but still we need more aggressive to have the therapy for this kind of DVT. And this is the small part of physiology that explain why it can happen. The thrombosis, if there is massive, it can be severe venous congestion and edema. There is a lot of fluid extravasation into the interstitial, and then the big high volume of fluid can be compromised the arterial inflow. And the arterial inflow, if compromised, it can be tissue damage, tissue ischemia, and necrosis. So in that kind of severe DVT, we should more aggressive. We should do more than only the anticoagulant. We will discuss next. And then also we have acute DVT and chronic. Acute when we define as less than 40 days, and chronic when we see the DVT is after 28 days. And how to establish the diagnosis of DVT? ASVS in 2021 declared that someone with DVT should start with pretest probability. We can use the Wells score. If there is score more than 2, we should call with DVT likely. And how to confirm? We use duplex ultrasound to confirm there is thrombus or not. If there is thrombus, the diagnosis is confirmed. If there is, after we do the ultrasound, there is negative, we can repeat 5 until 7 days after. And if there is no thrombus, we can exclude. But if there is thrombus, it confirmed positive. Otherwise, if there is the score is less than 2, it can be DVT unlikely. So we should do the dimer measurement. If there is the dimer higher, more than 500, we can proceed to duplex ultrasound and confirm the thrombus. And then if there is negative, we can exclude the DVT. So after we know the definition, classification, and how to explain the DVT, we more specifically now learn about how to do the strategy. After we confirm the DVT, we should have the bleeding risk stratification. If there is high bleeding risk in the right arm, this one, we cannot give our patient with anticoagulant. So just prevent the patient for the serious complication like pulmonary embolism. So we put the inferior vena cava filter to prevent the traveling thrombus go to arterial pulmonal. But if there's low risk or low to high, we can still use early thrombus removal, or we can use the anticoagulant to diminish the thrombus. And then if we do the anticoagulant therapy. Anticoagulant is mandatory for DVT if there is no contraindication or there is low bleeding risk score. So if there is, we use anticoagulant, we can divide into 3 phases: initial treatments along 21st day, and then principal treatment in 3 until 6 months, and then extended treatment if there is unprovoked DVT more than 6 months, we can continue the anticoagulant. And then this is our main topic, and how and when we do the interventional modalities for DVT. Traditionally, anticoagulant only prevent the clot growth, but interventional breakthrough, interventional perspective as catheter direct thrombolysis and percutaneous thrombectomy allow us to actively remove the clot burden, restore the venous flow, and reduce the long-term complication. And this is when. So when we do the interventional therapy for DVT, we decide to endovascular or do the intervention when we found our patient with the proximal and extensive DVT, and then we have the longer life expectancy, and then we found the patient with severe symptom like preeclampsia, dolens, and low bleeding risk. We should go to interventional therapy. And then we can use anything. There's some principle that we can do in interventional modalities. We can do the CDT, we put a catheter and do the thrombolytic there, and we can use the pharmacomechanical to remove the thrombus, or maybe we combine thrombolysis and thrombus removal. And then in recent years, several percutaneous devices has been developed to improve our thrombus removal technique. Previous speaker already talked about these modalities, and the choices often depends on what is available in our center and also operator preference and experience. In Indonesia, we have Angiojat, we have Penumbra, we have a course in next month, maybe hopefully all of the modality we can use in Indonesia or in Asia. Okay, I will share to you. I have 2 cases, and let me discuss with the first case. This is the first case. A 58-year-old male come to us present with the pain, swelling of right lower limb. He had carcinoma as the risk factor of focal cord diagnosed 4 years ago, for which he underwent surgery, resection, and no prior DVT before, no diabetic, no hypertension, no CVA. And we calculate the well score is high, 5, so DVT likely. Because DVT likely, we should do the ultrasound Doppler. In ultrasound, we found that there is complete occlusion and dilated vein in the right external iliac, common femoral vein, and popliteal vein. After the diagnosis confirmed, what should we do? We do the risk of bleeding stratification. We calculate the patient have the low risk score. So our diagnosis completely becomes provoked because of cancer proximal in right lower extremity DVT with low risk of bleeding. So in this situation, we choose for early thrombus removal. And then we start with, this is the process. We have the patient in the prone position, and we use the ultrasound guided to puncture of the right popliteal vein, and we put 6 French sheet. And then after this, we cross with wire 0.18 with the microcatheter Rubicon to go to the proximal. And then after this, we do the diagnosis. As you see, there is a lot of or massive thrombus from the popliteal vein, goes to femoral, goes to iliac vein. There is a lot of thrombus there. So this is a very massive thrombus that we can find in this patient. So what we decide, and then we decide to doing mechanical thrombectomy with Angiojat Silante 8 French. And before we do the fragmentation and thrombectomy, we do the pulse spray. 10 milligrams Altiplasa, we spray to that thrombus. We waiting for 30 minutes, and then we do the thrombectomy and this is the result after the thrombectomy with angiojet. We see the better flow in from the popliteal, and is good into the femoral. But we think this is still occlusion. This is a stenosis in the iliac. So our team decided to, because there is still occlusion, we put a stent. Because if we not put a stent, this is occlusion can make a stasis, and stasis become a thrombus in the next time. So we put a stent in the iliac, common iliac vein. We put a stent 14 with the length 60, and we see we have a good flow, better flow in the popliteal until the ostium of iliac. So this patient was discharged from the hospital 3 days after the procedure and continued treatment with oral anticoagulant. And this is the second case, different with the first case. The previous one, we did the thrombectomy in private insurance, in good funding, in good insurance. But in Indonesia, we still have problem with the national insurance. We can do anything with the private insurance, but if we do in a general hospital, in government hospital, we have limitation for funding. So in the next case, I will discuss about how about in limited resources, what can we face this kind of problem. As you see, this is a 52-year-old female present with unilateral swelling of the left leg for 3 days. And there is pain, there is numbness. If you say there is a color change, become blue, this is phlegmasia dolens. And the patient have hypertension, diabetic, and the patient in 1 month have immobilization because there is problem with the spinal, and then there is no history of malignancy or cerebral vascular disease. So same with the previous one, we calculate the well score is 5. So this is slightly defeated. So we proceed to ultrasound. In the ultrasound, same as the clinically, we found the thrombus, a lot of thrombus in popliteal until the common femoral and the external iliac vein. So because this is the limited resources, we can only do the CDT, because if we explain the funding, there is only enough for 1 wire, 1 sheath, 1 catheter, and 1 alteplase. So we cannot use the thrombectomy, we cannot use stenting. This is very expensive. So we did the CDT. We check the thrombolytic contraindication first. There is no absolute or relative contraindication. So we will, this is our planning to have 5 milligrams and then for bolus, and then we continue with the pump. And same as the previous, the patient have the prone position, and we puncture with ultrasound guided, and we put 6 French seat there. And then this is the diagnosis. We found a lot of thrombus from popliteal, and then goes to femoral, and then to the iliac. So what is the difference? This is our modality with 1 wire, 1 catheter. We use the modified side hole. This is the MP catheter 5 French diagnostic, and then I make the hole, side hole there with the needle. In all of the part of this catheter, we make the side holes. And after this modified side hole, we put this modified side hole to this patient. We make the modified side hole is cover all of the thrombus site from the proximal until the distal of a thrombus. And then before we put the catheter, we make a bolus injection 5 milligrams, and then we continue with 1 milligram per hour for 24 hours. So what is the result? The result is good. As you can see, this is flow restore from the popliteal until femoral, and also to the common femoral and iliac. So even in the limited resources, and our team satisfied for this result. And we do evaluate the ultrasound. There is already flow, and the common femoral can be compressed. And after we evaluate in 3 months, we see from the blue, and the big one in the left leg becomes more smaller, and there is no blue color without any complication for this patient. So in limited resources, we are happy to doing this case with limited resources. And as the conclusion for my last 20 minutes is, DVT remains common and is among top 5 vascular disease globally. In Asia, we have serious problem because we have lower incidence, but the mortality remains very high. Anticoagulant still mainstay therapy. Endovascular intervention provides significant benefit, especially if there is severe cases like preeclampsia. And in limited setting, don't give up. We can use catheter-directed thrombolysis as valuable, cost-effective to doing the revascularization for our DVT patient. I think this is my presentation. Thank you.
Thank you, Dr. Madikar, for such an excellent presentation and demonstrating the excellent result. What is most important is, in these cases, early identification of these problem. As early as you can do thrombolysis, the result would be better. And the catheter-directed thrombolysis, particularly with the catheter which has multiple holes, is a safe technique and is very effective technique. That has been shown by you, and it should be followed in most of these places when it is recognized early, so as to prevent the long-term complications of DVT. Otherwise, a DVT has long-term complications also. When it gets organized, the flow is restricted, there is long-term complications, and so these also can be prevented. Apart from pulmonary embolism, that is another problem. Any other questions or comments?
Can I ask one question?
Yes, please go ahead.
Yeah, hi. Sometimes it's very difficult that when the patient have the deviant thrombosis, the symptom got very, very severe. So of course, if the patient got extreme severe symptom, we can go for the endovascular intervention. But sometimes when we're treating the patient with the anticoagulation first, and then the symptom relief a lot, but still, if we can check the sonography, there's still a lot of thrombus over there. So what is the a strategy for the intervention timing? I mean, if the patient symptom is much, much better, will you still wait for much, much longer to see whether anticoagulation can work? Or there is a timeline that we treat anticoagulation for several days and then we go for the intervention? What is your opinion?
Thank you, Dr. Lee. This is interesting question. So in my practical, we just assess the patient with the target organ damage first. If there is critical ischemia, like we found in preeclampsia, cerebral dolens, we have no much time, Dr. Lee, to wait. So if I have severe clinically like preeclampsia, we proceed immediately to embolectomy. But if there is edema only, there is still no targeted organ damage, there is no dyspnea, or there is no suggestion for pulmonary emboli, I agree with Dr. Lee to wait and use the anticoagulant first. But once again, if there is massive thrombus with target organ damage like preeclampsia dolens, in my case, we should do immediately. There is no time framing, how long we wait, and etc.
Another thing that we can do is, along with this thrombolysis, catheter-directed thrombolysis, aspiration of this thrombus along with thrombolysis. This has produced a very quick result. With the help of this guide catheter itself, you can aspirate a large amount of thrombus, and the limb can improve immediately, along with thrombolysis. That had been my experience.
Yeah. Thank you, Prof. Sanjay. So in some cases, I also use the catheter 6 French, 7 French, maybe to have aspiration. But in DVT, we always got a lot of or massive thrombus, Professor Sanjay. So need a long time, many times to do the thrombus with such a manual thrombus with only we only have one catheter in limited resources. But this is, I think this is good idea. Thank you, Prof. Sanjay.
Any other question, please?
Hello, sir. I want to ask you, sir, after catheter guided thrombectomy, how much duration we have to give treatment for acute cases?
Sorry, it is not clear. It's about anticoagulant.
How much duration and how we decide or how long we have to go? Means depending on the causes of DVT.
The question is, how long do you have to do thrombolysis in these such cases?
Okay.
24 hours is enough?
Okay, for thrombolysis, yeah. Yes, in our case, it's 24 hours. Start with 5 milligram bolus and then 1 milligram in hour for 24 hours. And then evaluate after 24 hours.
So, sir, I am asking either it provoked or without any provoking factor such as anticoagulant factor deficiency, the treatment duration differ or same?
Okay, the question is, when there is anticoagulant factor deficiency, how long do you have to treat? These have to be treated on long term, like more, maybe not only 3 years anticoagulation, but lifelong anticoagulation. If you have factor deficiency, then they need anticoagulant therapy lifelong, particularly vitamin, not the direct thrombin, direct acting DOACs can be used in such situation for long term.
Thank you, Prof. Sanjay. Thank you for the question. So there is a reason why we use anticoagulant. So we have classification provoked and unprovoked. If there is provoked, we do the default strategy for anticoagulant. We have acute therapy with your principal therapy until three months, and then we evaluate. If the provoked or risk factor is diminished, finished, not be the risk factor, the anticoagulant stop in the 3 months. But if there is unprovoked, there is unclear the risk factor, we can continue the anticoagulant until maybe lifetime if there is recurrent DVT there. And in my practices, if there is unprovoked, we schedule for patient every 3 months to do the ultrasound Doppler, and then the anticoagulant with rivaroxaban as 10 milligrams, we continue until the lifetime. If there is evidence there is recurrent DVT for our such patient. So just find the risk factor specifically. If there is a risk factor, this is the time frame. If there is no clear, you have no clear time frames also. So just evaluate every 3 months and get the anticoagulant to prevent the DVT.
What oral anticoagulant do you prefer? The vitamin K antagonist or the direct acting anticoagulants?
Okay, I love rivaroxaban, Prof. Sanjay. So I use rivaroxaban because vitamin K we need use ENR evaluation in for regularly. So this is not satisfied for the patient. So I use the rivaroxaban 2 times 15 in the acute phase and continue with 20 milligrams in 3 months next.
Yes, that is our practice also. We use the direct acting oral anticoagulants in most of these because the monitoring of these INR monitoring is difficult in many of these situations when the patient go to the periphery. Thank you, Professor Mahadikar, for such an excellent presentation. I think we can go on to the next presentation. This is an interventional, the femoropopliteal artery disease with critical limb ischemia. Dr. Lee, please.
Hi, everyone. I'm Dr. Lee from Taiwan University Hospital. Today, I would like to talk about the interventional solution in femoropopliteal artery disease with critical limb ischemia. From this case, this is a 69-year-old man with recurrent right foot unhealing wounds for 8 months. So I think the duration is quite long. So the patient had been for help for many doctors, but the condition did not improve. So this is his history. The ischemic pain starts since 2020, had been treated with a long SFA to popliteal artery stenting for his SFA CTO. The unhealing wound started in 2022. He had been accept the PTA again and accept the amputation. However, the patient got still ischemic pain. So he had been treated with PTA again and uses the mechanical thrombectomy device with the Rotarex to his superficial femoral artery to popliteal artery in 2023 February. But according to the procedure details, the procedure could not reach the distal popliteal artery stent due to the size. And again, there's a new wound developed in 2023 August, and he accepted the PTA again for his recurrent SFA popliteal artery horny total occlusion. So this is the current status, as you can see, for his right leg wound. You can appreciate that there is a ischemic wound over here, and not only for the wound, but he got recurrent foot pain for his leg. So again, the wound progression from the initial very small shallow wound and then progress to the distal gangrene, dry gangrene, just like this. So progression again. So of course, he had been accept several procedures, just as I say, for the angioplasty for his right tibial peroneal artery, proximal PTA, popliteal artery, and the superficial femoral artery. So he had been done several times for procedure, want to relieve his leg pain as much as possible. However, I think the result is not as good as we think. Recurrent pain again. So this is the final comment from the procedure. For the SFA to popliteal artery, of course, he had been treated, but still recurrent again. So he had been suggested to take the AK amputation because I think the previous procedure, the wound progression and the repeat restenosis after several procedures. I think sometimes it's very difficult for the current decision because sometimes the procedure, the revascularization is not as good as possible. Once we have accept the endovascular procedure with the stent deployment, and then the choice we can treat for the repeat stenosis or thrombosis due to previous stent. The choice we can have is quite limited. So from February to August, and this is going to the November in 2023. So previous only small wound over here, still the wound is not totally recovered. But then you can appreciate that there is the new wound over the second, the third toe with the gangrene noted here. And there's a progressive gangrene over the third and the fifth toe, just like this. This is quite annoying to the patient and the suffering, and of course annoying to our doctors. So what to do next? So this patient was referred from other hospital to my hospital for the second opinion because he had been assessed several times of the endovascular procedure for his leg wound. What we need to know first is this patient got a very long SFA stenting and recurrent ISR occlusion. Of course, we know that once we got the stent inside the femoropopliteal artery, and then we need to pay the cost that we have the risk for the recurrent ISR. If the patient got very long stenting, and the risk is very high. So as we know, it is currently era of drug DCB balloon. Could we use the DCB, this new device, to his recurrent ISR lesion? Of course we can do that, but according to previous literature, the effect is quite poor because it is the long lesion. It is not the focal restenosis. According to the previous procedure note, it's the long neointima hyperplasia and the thrombosis and the total occluded. Another thinking is that yes, we have the recurrent ISR. Could we just bail out and do another procedure to put a very long cover stent just to bypass this stent area? It's called endoluminal bypass because we just put the stent from the very beginning of the previous stent to overcome the neointima hyperplasia, the thrombosis, the occluded of the previous stent. Yes, we can do that, but to remember that once we have the cover stent, the very important thing is that we need a very good distal runoff. Currently, we don't have the imaging, as I showed you later, but if we want to put the cover stent, the very important thing is that as possible as we can, we need to preserve the distal runoff as much as possible. We have 3 distal BTK, ATA, peroneal, and the PTA. If the distal runoff is too small, or we don't have the good distal runoff, the cover stent easily got thrombosis. And the thrombosis comes very acute. It's called to not only the critical limb ischemia, but going to the acute thrombosis. Then it is not the chronic case, the wound. You are going to have patient have the amputation. So to use the cover stent, we need to consider the condition as we mentioned. Of course, always we can seek for the surgical bypass because surgical bypass is the traditional and of course the standard procedure for this kind of long lesion. But we need to think about the landing zone. As I mentioned, the stent was put too long, maybe from the ostium of the SFA and to the popliteal artery. So what do we have? Do we have enough for the PTA or the ATA? And if we want to treat the BTK, sometimes it's very difficult to have the landing zone. We need to find the proper landing zone. And of course, the SFA still need to treat it if we want to treat the BTK. And the condition is quite common in our clinical practice. The patient refused for the surgery. they want only the endovascular intervention because it's less invasive and we don't need the general anesthesia, and we need is the local anesthesia. So what to do next? So this is the angio, as I mentioned. It is a very, very long stenting from the ocean of the SFA. I don't know whether you can appreciate that. The stent extends to the P3 area here, and it's totally occluded. You can barely see any vessel from the femoropopliteal artery. And then there's tiny collector from the DFA, and then recanalize again into the TB trunk, into this area. And finally, down to the foot. But if you check the angio from the foot, it is very, very barely you can see the very good BTK flow. So after this kind of angio, this is the first time I see the angio because the patient got several procedures in other hospital. So after the initial angiogram, we ask the patient again. The stent is long occluded, totally occluded from the very beginning of the SFA and to the P2 area. I'm sorry, P3 area. The outcome is poor. So we ask the patient again. But again, of course, again, the patient refused for the further open surgery for the bypass. So we start our procedure because it's the instant occlusion for this patient. So to pass the wire to the distal, sometimes it is easy, but sometimes it is very difficult because after passing the wire inside the lumen of the stent, we need to recanalize and to pass the wire into the true lumen in this area. Remember, this area is the P3 area. This area is very, very important because if we cannot treat this lesion well, if we damage this area, the lesion will again extend from the stent into the below the knee artery. And of course, if we damage this area, the risk for the reocclusion or stenosis is more easy. So we try to pass the lesion very, very carefully and then pass into the P3 area. So we treat the femoral popliteal first. We sequentially do the balloon dilatation. So this is a trick here. So once we pass the wire, if we robustly do the balloon angioplasty, sometimes there are going to be the thrombus inside the stent, and the thrombus will go further to the distal area and then run the risk for the distal embolization. So we carefully sequential do the balloon angioplasty, balloon dilatation here. And let's check further.
Not audible. Hello.
Hello, Dr. Lee, your voice seems not recorded. This part.
Okay, okay. So maybe you can just play the video, and I just like to mention by myself. Can you?
Yes, yes, please go ahead. The video is playing.
Okay, no problem. So,
Yep.
and of course, we do the after passing the wire, we do the sequential balloon dilatation.
Sorry.
And this is
Yeah.
okay here.
So after the angioplasty, as you can see here, now the flow is quite good. From the very beginning of the femoropopliteal artery and down to the P3 area. So of course, this is the area from the stent to the true lumen. A little dissection here, but mostly the flow is good. And then we can clearly see the angiogram from the foot here. So if you check the angio, we read the image like here. So this is the peroneal artery, and this is the PTA. I think the peroneal artery is diseased and recanalized here. The PTA here is not clear. This is a short occlusion with intravasal collateral and to the foot. And of course, for the ATA, is long occluded. So currently we have treated the femoropopliteal lesion. Is that enough? How to maintain the long-term patency? And of course, to remember that this patient got recurrent new wounds, the ischemic pain. According to the current guideline, if we want to treat the CLTI patient, not only the femoropopliteal lesion, of course, we need to treat below the knee lesion. So I think because from the previous procedure, he had been assessed several times of the femoropopliteal intervention, but again, new wounds, again, ischemic pain. So this time, I like to treat the below the knee lesion. There is the PTA CTO, ATA CTO, and what to do next? What is the vessel we want to treat? So this is the wound photo. We got several new wound and the ischemic wound and then the gangrene. Of course, after the first stage of the femoral intervention, the patient got heat, redness, and swelling. This is the signs of reperfusion. We don't have to worry about that. So after the intervention, you will see the swelling and the redness here, and this is the wound. So as I say, how to maintain the longer patency? The popliteal artery stent is too small but we have put a stent. Other hospital has put a stent already. We don't have any other solution currently once we put a stent. So the stent failure goes to the stent thrombosis, neoatherosclerosis, neointimal hyperplasia. What to do next? Of course, if we can try to prevent the neointimal hyperplasia, we can use the DCB, something like that, or the new starting medication. LDL for the patient is quite low, is the 74. So what to do next? We can give the medication with the new anticoagulation. And of course, we can increase the outflow. So how to increase the outflow? We have the target, PTA or ATA. For the intervention, I think we need to do frequent follow-up with the ultrasound to prevent the total occlusion as early as possible. So what is your choice for the PTA or ATA? So this is the angio. So finally, I choose the ATA because for the wound is mostly from the first and to the third toe. So we do the retrograde procedure from this area. This is the dorsalis pedis. So we have tried several times because the vessel is too small. So the first attempt, the wire cannot into the true lumen. And then finally, we do the retrograde smoothly, retrograde wire. The veins, and do this area with the reverse cut.
Okay, it seems that we don't have voice now, but I can, yes, just let the movie go. But and I can point out currently this is the retrograde strategy, and we are doing the reverse cut here to have finally into the true lumen. So the slide. Do we have still moving?
Yes, the slide's moving. You see the video still moving.
Yeah. Maybe we can jump to the later one. Can we?
Yes.
No. So and then of course we do the angioplasty.
The audio is intermittent, so
okay. Maybe jump to the later one. The final angio. Do we have?
So this is a wound. The wound seems that goes very smoothly, and no further ischemic pain for this patient. So for this patient, we have a take-home message. I think the ISR CTO is very annoying with devastating consequence. We need to think about the long-term patency during every procedure because for the ISR of the covers the stent ISR is very frequent once we put the very long stent. And if we want to treat the BTK lesion, retrograde, sometimes it is very easy if we can do the procedure with the purpose very clearly. So our goal is to minimize the vessel injury and the dissection when we are doing the retrograde procedure. Thank you.
So this is my cases. Do we have any question?
Yeah, my video has been disabled, I think, by the host. Hello.
Hi.
The video has been disabled by the host. It is showing.
Divorce means.
The video is from my side. The audio is there. What I wish to say, okay, it was a very tough.
Yeah,
But
the video is closed. Yeah, the video is ended. Yeah.
Yes, it was a very tough case, but you did it excellently. So congratulations for that.
Thank you.
So when there is total occlusion, you go for the from the peripheral from the periphery, you go from the foot retrogradely. How are you able to cannulate these obstructed arteries? What are the tricks of cannulating these in these totally obstructed artery from very small vessels in the foot?
Yes, I think also, first of all, I like to mention that, of course, the topic is going to do the femoropopliteal artery. But when we are doing the COTI patients, the most important thing is that we need to set up a in-line flow to the foot. This is from the guideline that we can do it staged. The first day we are doing the femoropopliteal, and then you need to choose another day to do another procedure for the BTK lesion. This is from the guideline. So very important that how to do it retrogradely. If the vessel is long enough, this is the coronary total occlusion. Sometimes it's difficult to recanalize the vessel from only one direction. We need to cooperate together, antegrade and the retrograde. So that's two strategies to doing the retrograde puncture. The first one is very easy. You can do the ultrasound. We do the ultrasound and then see the artery, and we are doing the puncture. This is also very easy. But sometimes it's very difficult because from the flow is very minimal, and sometimes the calcification is that severe and heavy. Ultrasound will be limited to see the flow if in this case is for the BTK lesion. So my personal strategy mostly like to do it with the angiography. So we do the angiography and then we see the flow and we do the puncture. This is my current strategy. I always do the retrograde bidirectional intervention when I am doing the coronary total occlusion. This case is very important that I think in previous intervention in other hospital, most doctors only do the instant occlusion. I think the instant occlusion to recanalize sometimes is very easy because it is stand over there. You just need to pass the wire to the distal part. But if you are doing only femoropopliteal lesion, don't forget the wound is over the foot. You need a direct inline flow to the foot. That is very important from this case.
Yes, excellent. The direct inline flow is very essential. And now we have peripheral drug-eluting stents, which we have used from Boston Scientific, which elute the drug for 1 year. And the chance of restenosis are very less as compared to the non-drug-eluting stents. The bare metal stents, from the bare metal stent, we have to go into the era of peripheral drug-eluting stents. And the results of restenosis, much lower restenosis we have seen in our experience.
Yes. Of course, currently now we have the jaw-eluting stent. It's from the Boston. Now we have the Illuvia.
Yes.
Yeah, we have
Yes.
the Illuvia. But
Yes.
again, all the stent, whether it's the bare metal stent or the jaw-eluting stent, finally, eventually, you will go to the restenosis. It's just the problem of time. So Illuvia, we can have the longer duration. But don't forget, if the patient got maybe after 5 years or 6 years, the patient got wound again, coronary total occlusion again. So how to treat this patient? I think the frequent clinics follow-up and the ultrasound is very important. Don't leave the patient to the coronary total occlusion for a long part. You just treat it once the patient got focal stenosis. That is very easy for you to treat. And of course, if you are using the jaw-eluting balloon, even in this kind of jaw-eluting stent, is the focal stenosis, the outcome is much better than the long stenosis or chronic total occlusion. So frequent visit is very important.
Yeah, very true. I think you have to have very quick surveillance and do it when there is focal stenosis instead of waiting for long total occlusion to develop. That's a very good point. Thank you, Professor Lee.
One question at the chat box. One question in the chat box.
Yes.
Lithoplasty. Okay, so of course, nasoplasty is another new device that we can have, but the device is used for the severe calcification. For this case, I don't think it's the problem about the severe calcification. It's about the stenosis inside the stem, the restenosis. Only if the patient, the restenosis is due to the crush of the stem due to the calcification outside the stem, then we can use the shockwave balloon for this case, but not for this. Okay, thank you.
Yes, absolutely true. It's not about calcification, but about crossing the total occlusions. And one must not forget these patients to stop smoking and the lifestyle measure, the statins and antiplatelets, the drugs are also essential. So patient need to be emphasized to stopping smoking because the distal circulation and control of diabetes is also very essential. These patients are often diabetics and the smokers get peripheral artery occlusions distal to the knee. And there is corkscrew appearance like Burgess type of arteries in many of these patients.
Yes, thank you.
We can go to the next presentation, Professor Lee.
Okay, allow me. Okay, so thanks. I'm going to introduce the next speaker. It's the Ankit Bansal from India. So he are going to have the talk about the intervention solution in Takayasu or aortitis with syncope. I think it's very important and rare. We are like to have this talk to share with us. Thank you.
Good morning, everyone. So, warm greetings from India to our esteemed speakers who have joined. My sincere gratitude to Professor Tyagi sir for inviting me for this talk and mentoring me in this difficult intervention area. So to begin with, are my slides visible?
Yes, very well visible. Please go ahead.
Yeah. So Takayasu is a chronic granulomatous large vessel panarteritis with a preferential involvement of the aorta and its major branches. It is more common among the Asian population and it's a special predilection for females, especially young females. Severe stenosis leads to organ ischemia, which may present with severe hypertension, heart failure, loss of vision, syncope, presyncope, TIA, and stroke. So, why syncope occur in Takayasu arteritis? It is the severe involvement of the arch vessels, which lead to cerebral ischemia, resulting in dizziness, fainting, presyncope, syncope, and loss of vision. Symptoms worsen with upright posture when there are critical stenosis. Critical lesions need timely endovascular therapy or open surgery. The vascular complications and mortality are higher with surgical procedures. That's why endovascular therapy is generally preferred. So let's see this case. This is a Doppler ultrasound of a carotid artery. So this is the diameter of the carotid artery. Can you appreciate the intimal thickening? The almost whole of the artery is obliterated and less than a millimeter of lumen is left. So this is the new intimal hyperplasia which occurs in Takayasu arteritis. We have to treat this hyperplasia. This is the panarteritis. So what should be the timing of endovascular intervention? Classically, it should be performed during the periods of disease remission. Good control of disease activity, both pre-operatively and post-operatively with adequate immunosuppressive therapy is essential. Sometimes a clinical scenario like intractable syncope, impending loss of vision, resistant hypertension leading to pulmonary edema mandates urgent intervention even before the complete control of the disease activity. So we should not wait in these difficult clinical scenarios for immunosuppression. We should start immunosuppression, do the intervention and continue immunosuppression. So what are the protocol? So the intervention procedure is usually done by the femoral root with a 7 French or 8 French axis. Loading dose of aspirin and clopidogrel are generally given. ACT to be maintained between 250 to 350 with unfractionated heparin. We can use either a guide approach or a sheath approach. If we are using a guiding, at least 8 French GR guide is recommended. or a 7F destination or a shuttle sheath can be used. Wires, we need to have a 300 centimeter coronary floppy tip wire or a 0.18-inch V18 or a steel core wire. Sometimes extra stiff 035 wires are required for delivering long stents. Balloon expandable stents to be used at aortosteal location, and self-expandable stents are preferred in the carotids and the extrathoracic portion of subclavian. So these are the differences between two types of stent. Balloon expandable are less flexible but precise positioning, high radial force favored in aortosteal location, and self-expandable stents are more flexible, more preferred for long lesion, tortuous vessel. However, the precise positioning is difficult. So few pearls for before starting a procedure. Always graded dilation to be done with a smaller diameter balloon. Balloon diameter should never exceed the 1:1 ratio. High pressure dilation is required for resistant fibrotic lesions, increases the success rate of angioplasty. However, it also increases the chance of dissection and may lead to stenting, and rarely it can cause rupture, which can be catastrophic. Use of appropriately sized cutting balloon is highly recommended. Important point, dilation should be stopped if the patient complains of severe pain because of the stretching of the adventitia. If the pain occurs, that is your end point. Aggressive post dilation should be avoided, and the residual stenosis up to 30% can be acceptable. While doing the carotid interventions, these patients often have high blood pressure due to cerebral autoregulation. And during angioplasty, sudden hypotension and bradycardia can be seen after relieving the stenosis, which can be treated with intravenous atropine and mefentermine. Highly fibrotic lesions lead higher pressure and prolonged inflation, and routine use of embolic protection devices is not recommended because these are virtually devoid of soft plaque and thrombus. While doing the vertebral intervention, it is only recommended when there is a severe cerebral ischemia and the carotid arteries are either totally occluded or they are diffusely diseased and the vertebrae are acting as the sole supply. Since the diameter of the vertebral artery matches with the coronary, all the coronary balloons, hardware and stents can be used in vertebrals. So coming to the case, I have 3-4 cases. As the time permits, I will go with the cases. So this is a 24-year-old female who presented with claudication along with pre-syncope and syncope for last 8 months, along with the exertional angina, and the echo is suggestive of severe LV dysfunction, moderate aortic regurgitation. The ESR was 20, CRP was positive, already on steroids. So this was the aortic arch DSA. We can appreciate the severe arch vessel narrowing, the narrowing of the vertebral artery, the narrowing of the right common carotid artery, critical narrowing of the right common carotid artery, critical narrowing of the left common carotid artery, and the critical narrowing of the left vertebral and the left subclavian artery. Also, the cause of angina in this case was the critical narrowing of the ostial left main. So these patients can also have the involvement of the coronaries and the pulmonary arteries. So this is the still image showing that in the RAO view, the importance of the RAO view is it gives the clear idea of the vertebral and the right common carotid artery bifurcation. When we take a RAO view, this is the right common carotid artery and this is the vertebral artery. So we can clearly appreciate this is the critical narrowing here, followed by aneurysm formation and followed by a long segment diffuse more than 90% stenosis in the right common carotid artery. So we passed a 0.14-inch floppy 300 centimeter long wire into the carotid artery and the lesion was pre-dilated with a long 5x60 peripheral balloon. And this was the result after the balloon angioplasty, a pretty good result. However, we can see a long dissection in this carotid artery. So in view of the dissection, this lesion was stented. And the lesion was stented with a Boston Epic 8x60 self-expandable stent. The carefully positioned stent The stent should remain below the bifurcation of the ICA, ECA, and should land just at the aneurysm portion. So this was the result after the stenting. The post dilation in the dilation in the just below the aneurysm was done, and this was the result. So you can appreciate the result here. This was the pre-stenosis, and this was the beautiful result. The stent is perfectly landing below the bifurcation into the just above the aneurysm portion. This portion was just balloon dilated. No stent was placed here as there were no dissection, and we got a very good result into the right carotid artery. Selective angiogram of the left carotid was also done. This was also a long segment stenosis. This was cutting balloon angioplasty with a 4x10 flextome was done. And this was the result after the cutting balloon angioplasty. We can appreciate again a dissection in this common carotid, left common carotid artery. This was also stented with a 8x80 self-expandable stent. Post dilated with a 640 balloon, and you can appreciate a beautiful result in this case. So almost we have achieved near 100% result in this case, and the artery has opened up very well and the distal circulation is very good. After 2 years, we did a follow-up angiogram. Still, there is a mild ISR, but the patient is clinically asymptomatic. The important point of paramount importance here is that we have to do a routine surveillance. Never let go these patients. We, in our institute, what we used to do is 6 monthly we used to do a Doppler USG to look for the distal flow, and whenever required, we supplement our evaluation with CT angiography or invasive angiography to find out the early focal restenosis, which can be treated with balloon angioplasty or cutting balloon angioplasty. Coming to the second case, this patient presented with pre-syncope and syncope for last 1 year along with headache, normal LV function, CRP negative, ESR slightly high, patient on mycophenolate. This is a still DSA showing the critical stenosis of the right common carotid artery. The left common carotid is normal, but the left vertebral is also critically stenosed. So selective angiogram of the arch vessel. The right subclavian artery and vertebral artery are practically non-existent in this patient. Long segment diffuse stenosis, and we should not try to open these arteries because of very poor outcomes. The right common carotid is critically stenosed. Also, the left subclavian artery and left vertebral arteries are also critically stenosed. So again, what we did is we passed a 0.18-inch 300 centimeter wire. We took a 5x20 peripheral cutting balloon, but you can see the watermelon seeding effect. Even with this cutting balloon, we are not able to treat this stenosis properly. The balloon is always going ahead. It is slipping from the stenosis. These lesions are highly fibrotic. That's why the cutting balloon angioplasty is recommended. But once the lesion is opened up, we can see a nasty dissection into the carotid artery. This dissection cannot be left because the vessel will occlude. So again, a 860 self-expandable stent was implanted. The lesion was highly fibrotic even after the implanting the stent, even after the cutting balloon angioplasty. We had a neck here. So these are highly fibrotic lesion. We have to we need prolonged dilation in these cases. You have to gradually increase the pressure by 1 atmosphere, 1 atmosphere, 1 atmosphere. And the moment either the patient experience pain or the neck disappears, you have to stop. So with the dilation of around 2 minutes, this neck disappeared, and this was a beautiful result after the post dilation. So you can appreciate this was the pre-lesion and this was the post result. Selective angiogram of the left subclavian artery was also done. Both arteries were wired. Cutting balloon angioplasty of the left vertebral artery was done, and also the cutting balloon angioplasty of the left subclavian artery was done. and this was the result after POBA. Still a significant residual stenosis and at the ostium of the vertebral artery. So what we did with a selective drug-eluting stent of a Zions coronary stent of 4x18 was placed at the ostium of the left vertebral artery because it matches the diameter of the coronary arteries, and we can get a beautiful result of the left vertebral artery. So we have increased the flow in the right common carotid artery and the left vertebral artery as well as the left subclavian artery. So this was the pre-image and this was the post result. Coming to the case 3, this patient presented with blurring of vision, pre-syncope and syncope, and their symptoms were classically worsening on standing. The patient had CRP was positive. Patient was already on mycophenolate. So we cannot wait in this patient for CRP to come down because already the vision is going. Patient is even cannot stand. We did the fluorescent angiography and the arm to retina time was around 30 seconds. So the normal time is 8 to 16 seconds and it was almost twice of the normal time. And there was microaneurysm in both the eyes. So the baseline DSA was suggestive of critical stenosis in all the arch vessel. Right common carotid artery practically 100% occluded. Right vertebral artery almost 90% stenosis. Left carotid artery long segment diffuse 90% stenosis, and left subclavian artery 100% occluded, filling retrogradely. So this was a selective angiogram with the 7 French destination sheath. We can see this is a 99% stenosis of the right common carotid artery with a distal flow which is reduced. Prolonged balloon angioplasty was done and we have to gradually inflate the balloon till the neck disappears. This was the result of the balloon angioplasty. Significant dissections were seen. A Merrill peripheral 6x57 balloon bare metal stent was used here. Good result after the stenting. And we can see this was the pre-angiogram and this was the angiogram after the stenting. Beautifully, the artery has opened up and distal circulation has increased. To further increase the flow, because we should increase the flow as much as possible because this patient was highly symptomatic. So we wired the right subclavian artery and the right vertebral artery, and the cutting balloon angioplasty of the right vertebral artery was also done, and the flow into the right vertebral artery significantly increased without any residual dissection. So this was the pre-image and this was the final result. We can clearly see the significant increase in the distal flow into the right common carotid artery, right vertebral artery, and this patient was planned for second sitting stage procedure into the left common carotid artery. So we recommend a post-procedural follow-up of dual antiplatelet for 3 to 6 months. Then monotherapy can be continued. Long-term immunosuppression to control the disease activity. Monitoring the disease activity by ESR, CRP and activity scores. Use of adjunctive immunosuppressants or biological like tocilizumab in a dose of 8 mg per kilogram every month in refractory cases to control the disease activity in patients with recurrent restenosis after endovascular intervention. My take-home messages are endovascular intervention should be done only in highly symptomatic cases, ideally after controlling the disease activity. In severely symptomatic patients like recurrent syncope, seizures, loss of vision, intervention may be done after starting the immunosuppressants, and we should not wait till the control of disease activity. Restenosis and de novo lesions can occur even after adequate control of disease activity. Repeated CT, conventional angiogram or ultrasounds at 6 months can pick above lesions at early stage, which can be tackled by cutting balloon angioplasty. While the restenosis focal, it is easy to treat. Once the restenosis become complete occlusion, it is very difficult to treat these lesions, and going into the false track, reverse cart, Carlino technique, all these techniques which are very common in coronary or in the other peripheral vasculatures are very difficult to do or are not recommended to do in the carotid. So we have to pick up these restenosis or de novo lesions at earlier stage, and we have to treat these at earlier stage. So routine surveillance is of paramount importance in the arch vessel angioplasty. Thank you so much.
Thank you, Professor Ankit, for such excellent cases. Remarkably good results in such difficult situation where the arteries are totally occluded, patient is severely symptomatic. So most importantly, one should try to identify these patients in an earlier stage where we can help these patients in a much better way. But as Professor Ankit has said, the surveillance after angioplasty is also very essential. As soon as the patient starts developing restenosis, the repeat intervention is required. Also, continuation of immunosuppressive drugs is also very required for long-term follow-up in these patients. So, any other questions or comments on the Professor Ankit's presentation? Professor Lee? You must also be seeing such cases of Takayasu's arteritis.
I think currently for the Takayasu disease in aortitis, sometimes it's mostly focused on the osteo lesion. Sometimes we'll wonder that because the osteo lesion for the aortitis, the calcification is very, very severe. So of course, we can do it robustly, just doing the balloon angioplasty for this area. And we wonder that do we have any device preference that to choose in this area? Should we use the cell-expandable stent or balloon-expandable stent? The first one. And then the second one, currently now we have the drug technology. Do we need the drug technology in this area to use the drug, or just we can use the bare metal stent? That is enough. Thank you.
Your comment is very important. I think you have made an important point. The drug technology, what we have seen recently since the availability of drug-eluting peripheral stents, as we discussed previously, the results are better, restenosis rate is lower, but importantly, one should remember that in these patients with Takayasu arteritis, mostly the common carotid artery is involved. Internal carotid artery is often spared. So if one is able to recanalize this common carotid artery, one is able to improve the cerebral circulation. Surgeons also don't want to touch these patients. We have often referred them to for surgery, but surgeons also don't want to do these patients. So these patients are very, very sick patients with very few limited options. And I think all over Asia, not only India, but also Taiwan, Korea, Vietnam, Japan, China, all these are very not uncommon situations. I think we all are facing such situations. So any other questions to Professor Ankit? I think it has been a wonderful presentation, Professor Ankit, and
thank you so much, sir.
Deeply appreciate your showing such difficult cases and good results. We can go on to the next presentation on the interventions in chronic thromboembolic pulmonary hypertension from Japan.
Thank you, Chairperson. Can you hear me?
Yes, yes, very well.
Okay, thank you. I will share my slide. Can you see my slide?
Yes.
Thank you so much. It's my honor to give presentation here. I'm Taiji Sato in Tokyo University Hospital, Department of Cardiovascular Medicine. I'd like to talk about new BPA strategy utilizing pressure caster. We have no COI. In the patient with CTEPH, the organized thrombus disturbed cardiopulmonary circulation, which led to the poor prognosis. Due to improvement of method for diagnosis in Japan, the number of patients increased in Japan around 4,843 patients is very similar to PAH patient. Oh, sorry. So the multimodal therapies should be considered for the patient with CTPH. Proximal region side is appropriate for PEA, while distal region is appropriate BPA, or remodeling of small distal pulmonary artery should be considered for administration of pulmonary vasodilators. Those combination therapy has improved their prognosis. In Japanese CTPH registry, 5-year survival rate CTPH were 10.2%. In the group treated with BPA and 16.1% in the group treated with PEA. These data indicate a similar improvement of their prognosis. Due to Kabuki trial, latest Japanese guideline include DOAC as class 2A as anticoagulation therapies. Moreover, while previous guidelines prioritized the consideration of the PEA indication, latest Japanese guideline equally considers the indication of PEA and BPA. Moreover, after BPA session, peak cardiac index during CPET changed largely better in the cigarette continuing group than in the real cigarette discontinuing group. So current treatment strategy utilizing pulmonary vasodilators after BPA improved exercise tolerance, not only hemodynamics or prognosis. So I would like to introduce our current work utilizing pressure catheter. Current strategy of pulmonary angiography with pulmonary vasodilators improves the prognosis of patients with CTPH. After improvement of BPA strategy, we have still experienced the residual pH even after BPA session, such as mean PRP larger than 25 mmHg or PVR larger than 300 centimeter. Moreover, I would like to move on the adverse event. I improve of BPA strategy, including size of balloon and the number of target vessel per BPA session, largely reduces the adverse event. However, around 5 to 10% BPA session was still related to any types of adverse event. So we have discussed remained issues in current BPA strategies. Some patients show the residual pH after BPA session, indicating the presence of remained PL region. Adverse event may be related to over-dilation of balloon or repeated deep wiring in small region. So new approach to evaluate the region would be needed for BPA strategy. Among several options, we focused on pressure analysis and utilized nervous. Angiographical approach may be sometimes hard to distinguish the region. Please note the pressure analysis measure the pulmonary artery distal pressure and the pulmonary artery proximal pressure, and we analyze ratio. Thus, in which smaller value means severe stenosis. While type 2 showed good PA flow, but the OCT demonstrates the Rutus region, and the pressure ratio is very lower. And while type D showed the Rutus region, but the pressure ratio was normal. So the pressure analysis can correctly measure the blood flow rather than angiographical analysis. Previous research already demonstrates the pressure ratio correlated with pulmonary flow rate, largely depending on pulmonary vein flow. However, pulmonary flow grade was hard to determine the value of cutoff target ratio, as the grade is ordinal value. So usually, actually, we don't perform DSA in BPA session, but today I would like to show the slide to demonstrate the flow detailing. I will show DSA image in this slide. In angiographical approach, we check the PV flow following pulmonary flow grade. As you can see, pre and post BPA pulmonary flow grades seem to be same as grade 3. Even in pulmonary flow grade 3, pressure ratio 0.652 before BPA, very lower. And after BPA, the ratio increased 0.83. This data indicates that pulmonary flow grade 3 may have residual flow limitation, but the evidence was not enough to determine the pressure target ratio. So to evaluate lung perfusion, we placed the rods around the sensor of pressure catheter to evaluate lung perfusion, wash-in rate or wash-out rate, or peak, time to peak, or AUC. But we are evaluate the before and after BPA. So for example, regarding wash-in rate, lung perfusion were not statistically improved in the pressure ratio more larger than 0.5. On the other hand, wash-out rate larger than 0.7, the statistical significant change disappeared. So in pressure ratio larger than 0.7, all parameters did not show any more improvement in lung perfusion, indicating this is target pressure ratio. So we aim to evaluate the efficacy and safety in new BPA strategy depending on pressure ratio 0.7. So we hypothesize that pressure guide BPA showed additional improvement of pulmonary hypertension associated with lower adverse event. The patient were enrolled between April 2022 and 2023. This is not actually not RCT. Angiographical approach BPA were enrolled between 2020 and 2022. Same BPA team and members performed all BPA sessions. Efficacy endpoint were after all BPA session, the patient shows lower mean pulmonary artery pressure 25 mmHg and PVR 300 to dying. Safety endpoint is complication rate related to BPA session. Major complication is needed to additional treatment such as NPPV or coil treatment. And minor complications were no additional treatment. Actually, the angiographical approach group took several types of pulmonary vasodilators according to the guideline at that time. And the BPA sessions mean before BPA in angiographical approach group, mean pulmonary artery pressure relatively higher in angiographic group, which was one of the limitations. This slide shows the result. Pressure guide BPA based on target ratio 0.7 shows higher achievement less than mean pulmonary artery 25 mmHg and less than 300 to dying. So BPA based on target pressure ratio 0.7 shows higher achievement of improvement. Finally, univariate and multivariate logistic regression analysis demonstrates that pressure guide strategy was independent factor of higher achievement of the pulmonary hypertension. And I'd like to discuss about safety endpoint. In angiographic approach group, ballooning were routinely performed from subsequent to proximal side, which were associated with a higher adverse event. On the other hand, pressure analysis demonstrates that most of PA region located sub-segment level, which were associated with lower adverse event. This reason is plausibly that pressure analysis can skip the unnecessary wiring or ballooning in small vessel. So in conclusion, pressure guide BPA shows additional improvement of hemodynamics associated with lower adverse event in comparison to angiographical approach BPA. I would like to thank my colleague and collaborator. Thank you for kind attention.
Thank you, Dr. Sato, for such an excellent view of this another difficult situation of thromboembolic pulmonary artery hypertension. We know that in Japan, a lot of work has been done in this area and which has improved the results of chronic thromboembolic pulmonary artery hypertension. Just a small question. Sometimes patients which present to us with thromboembolic pulmonary hypertension have severe systemic or suprasystemic pressure. Is it safe to go ahead with balloon pulmonary angioplasty in such situation?
Actually, my university, it depends on cardiac index. Even if they show lower systemic blood pressure, it should be okay. For example, 80 or 90 millimercury is safe for BPA sessions.
Okay. Then you have to do multiple sessions. You in a single session, 3 to 4 arteries are opened in a single session. Is that the procedure?
You mean the number of BPA sessions?
BPA sessions, yes.
We usually 4 to 6 BPA session. All patients need 4 or 6 BPA session because it depends on the dose of contrast or like a radiation.
These patients who have very severe pulmonary artery hypertension, do they have higher chances of pulmonary hemorrhage or pulmonary edema?
Yeah, especially at first, they show the relatively higher mean pulmonary artery pressure, especially more than 40 or 50 millimercury. They have a risk to like bleeding. So we start the drug treatment with pulmonary vasodilators at first, and we try to reduce the mean pulmonary artery pressure at first, and then we try to perform BPA session.
Good. Any other question or comment from any of the chairperson, Professor Lee? Any question or comment by any of the panel members? If none, I think all the presentations have been outstanding presentations, and the focus of the APSC, Professor Lin, on this vascular interventions has been very important because this is often a forgotten area in the treatment. We mostly concentrate on the cardiac aspects, but vascular aspect is often forgotten. So thank you, Professor Lin, for organizing this seminar of the Asian continent, right from Vietnam to Taiwan and Korea to Japan and China. All the areas were covered. Thank you, Professor Lin, and thank you all the presenters for such excellent cases. We may now close this session. Thank you.